think number one is that, precision medicine is about using the current and best science. Typically, new laboratory testing, data. It may be, patient-specific genomics. It may be certain biomarkers that help better predict a patient's response to therapy. But in short, a lot of times it's about using the best science, laboratory data where available, to help guide and select the most appropriate medication. Because no one medication is going to work for every single patient. There are unique member-specific variabilities and differences that increase or decrease the likelihood that a medication is going to work well. So, for example, in the treatment of rheumatoid arthritis, we know that the common drugs like Enbrel and Humira, the anti-TNF products, typically fail, 40 to 60% of the time. And so as new tests become available that help you increase the likelihood of success, knowing who the drugs may work for out of the gate and who the drug's not going to work for out of the gate, helps to improve, eliminate waste, right? Because you're not starting patients on medications that aren't going to work, but it also helps delay disease progression. So you end up with a happier patient, so rather than having another 6 to 9 months of joint erosion and disease progression because the drug was never going to work, you're able to get them on the right drug, more quickly, right? So that's one of the key things that we kind of see and really want people to understand, that there are a number of new tests that are becoming available. Some of them have been approved by the FDA. Some of them are still in process, but there's a lot of research and development being done, in this particular area. And we're really excited to be using that to help guide treatment decisions. Patty, you want to hit our second takeaway?
Yeah. Just to kind of add on to what Nick is saying, what's really important about being able to get patients on the right therapy from the very beginning is that you're going to have that better patient engagement. You're going to have these patients that are going to be more engaged in their healthcare. They're not going to want to give up or feel defeated because the medication that they're taking for their disease state is not working. And so it's really important. There is a lot of value in that early kind of treatment success, rather than having them kind of do that trial and failure where, not only is that you're going to have the disease progression, but psychologically for those patients, it might make them kind of withdraw or maybe not want to be engaged in their healthcare. Another, and as Nick was mentioning too, by doing this, there's really an improvement in cost. And it's not just cost for the clients, but it's also for those patients, right? It's going to help improve, needless, co-pays that for a drug that wasn't going to work for them, or they think it might work after a while. And unfortunately, it won't. And so it allows us really to, avoid unnecessary treatment escalations in drugs that are never going to work for that particular patient.
Of the tests that we're looking at are more mechanism of action, of a medication. So one of the tests that we focus on is a test called PRISM-RA, and it identifies whether the class of drugs of anti-TNFs, of which on our formulary there are some that are formulary and some that are non-formulary. So it's not drug specific for the most part as it is mechanism of action, specific. So you're able to say this class of drugs is likely to work for the patient, or this class of drugs is likely not to work for this particular patient. And then within that therapeutic class or mechanism of action, then you can select the formulary agent that you do want to use. So most of the tests that we're looking at and have been developed fall more into that kind of category. So I don't think it has as much of an interplay. Certainly, there are some pharmacogenomics tests that are very specific to that drug. And so it's probably more of not necessarily rethinking the formulary, but there may be some medical exceptions. It may be, yes, this is a non-formulary medication, but the reality is it is the best treatment choice for this particular patient. It's the only thing that's going to work. So it just may have to be approved through, appeals or medical exceptions process. So not sure that it would, necessarily need to overhaul the formulary strategy, but certainly need to think through how we think about the exceptions when we know the science says this is the best treatment option for the patient.
Yeah, I mean, just to reemphasize the point, these these are tools that we use that we can layer on top of an existing formulary as we're helping managing these particular patients.
My initial reaction is that while we've been talking about it for a while, if you go back, a decade when we were talking about, the early stages of precision medicine, or it was even really kind of more personalized medicine was kind of, some of the earlier terms that we were using. And it was more of along the line, when you think about it, there were certain drugs that as part of their FDA labeling say that this drug should only be used in patients that have this particular pharmacogenotype. And so, yeah, that's kind of advanced. And I would say that most everybody incorporates that into their prior authorization, medical certification criteria, right? So that's pretty advanced, but that's, simple FDA indications kind of thing. What we're really looking at, at the tests and the precision medicine things that we're looking at, adopting are new technologies, right? Where maybe the concept's been around for a while. I mean, the tests that we're talking about, you trying to, look at today, have only been on the market for a couple of months or a couple of years, right? And they're a little bit different because it's not part of the FDA labeling, right? It's more around what are these patient-specific nuances. And so, and there's even, one company that we're working with that their motto is to go out and they're not the genetic experts, but what they're doing is they're going to multiple other genetic companies that have some expertise in an area and say, we've been talking to the payers. And the payers say they've got a problem with psoriasis. And can you help create tests, specifically to psoriasis management? And so it's actually working in that way, that there are some companies that are focusing very much on where's the need, right? Rather than saying, hey, I've got this great science. There are some people that are saying, hey, here's the need. Do you have science that kind of matches up with it, right? And now they're kind of going down. So now rather than saying, hey, this drug should only be used in this, hepatitis genotype, right? So that's a form of personalized precision medicine. This drug's only effective in these genotypes. This is much more saying, hey, look, this drug, for the 3 mechanisms of action to treat psoriasis, we know that JAK inhibitors are going to work for this patient, and anti-TNFs and interleukin agents are not going to work, right? So it's a different level. And then you start talking about the oncology space. And it's, in the growth in that, I mean, daily, just what we're learning about, the various different, genotypes. So I think that's where there's going to be a lot of growth, but we're seeing a lot of focus, in that inflammatory space, whether it's rheumatoid arthritis, Crohn's and ulcerative, colitis, as well as psoriasis. There's a lot of work being done, but also there's a ton of work, as you would expect, being done in that oncology space to better guide, treatment, so that you can get patients to first or second line treatments that maybe would have been third or fourth line treatments, based on, NCCN guidelines, but knowing the specifics, you get people on the right drug, from the very start.